All right, good evening, everybody. I've got just a little after 6 o'clock, so we're going to go ahead and get started. Welcome to our joint pain webinar this evening. My name is Elise Hilskamp, and on behalf of Premier Health and Premier Health's orthopedic specialists, I'd like to thank each of you for attending this evening. We're very glad to have you with us, and hopefully you are staying warm in the comfort of your home joining us this evening. Tonight, we are here to discuss joint pain. As you may know, joint pain is a common issue for many. You are not alone. The good news is that there are options available to help reduce your pain, increase mobility, and get you back to the activities that you love. Our physician expert, Dr. John Powell, will give a brief presentation this evening on those options. He will also answer some of your questions following his presentation. To submit a question, I just want to bring your attention to your screen. If you scroll your arrow down to the bottom, you'll kind of see some buttons down there, mute. There is a Q&A button at the bottom of your screen. That is where you will type in your questions this evening. You can submit your questions at any point of the presentation, but we will be saving them until the end. So there also may be a chat button on your screen, but please disregard that for this evening and send your questions by clicking the Q&A button. We will try to get to as many of them as possible this evening. We are recording tonight's event, and we will send you a link to it in the next few days, should you want to go back and view all or part of the presentation again. So without further ado, let's start off our evening by introducing our speaker. Dr. John Powell earned his Doctor of Medicine degree from the University of Kentucky College of Medicine and completed an orthopedic surgery residency at Indiana University School of Medicine. A veteran of the United States Air Force, Dr. Powell has served as Commander Orthopedic Surgeon with the 655th Forward Surgical Team, Forward Operating Base in Ghazni, Afghanistan, and was the Orthopedic Surgery Flight Commander for the 88th Medical Group at Wright-Patterson Medical Center. We certainly thank Dr. Powell for his service. Dr. Powell specializes in orthopedic surgery and sees patients in his Englewood office located at Miami Valley Hospital North. He practices at Premier Orthopedics, one of the largest and highly trained orthopedic and sports medicine practices in Southwest Ohio. The practice offers the full range of treatment options from exercise and physical therapy to injections, pain management, and surgery when needed, including minimally invasive arthroscopic and robotic procedures, all of which you'll learn a little bit more about tonight. With nearly 30 doctors and more than 12 locations, Premier Orthopedics is ready where and when you need help. So thank you, Dr. Powell, for being with us this evening, and I will turn over the presentation to you.
Again, thank you for the wonderful introduction there. I was a veteran of the Air Force, and we got bit by the Dayton bug when we lived here. My wife, it came time for me to decide whether or not I was going to stay in the Air Force, and my wife looked at me and said, I think you need to find a job. I kind of like it here. And so that's exactly what I did. To go over a little bit, I do specialize in orthopedic surgery. I do a lot of work in the realm of total joints, particularly in robotic joints, and also do a fair amount of sports medicine work, particularly hip arthroscopy. So you'll see a little bit of that kind of in today's discussion. So what are we going to talk about? Well, we're going to talk about a whole lot of things, and some of them we may kind of come back to and hit on a couple of different slides, but we're going to talk about the common causes of joint pain, how to get a proper diagnosis, and what those treatment options are, all the way from non-operative to operative. And when we decide that we need to do surgery, that surgery is the next best option, deciding kind of what those options are and how that will play out, and what the best choice for you to make as the consumer in this. So common causes of joint pain, again, most of the you have the acute injuries, you have overuse or chronic injuries, which kind of occur slowly over time. The ones that occur over time, we tend to kind of lump into what we call degenerative symptoms. So when we talk about things like osteoarthritis, that tends to be more of a degenerative type of a joint pain. What is a joint? Let's start at the very basics. Well, a normal joint is any interdigitation between two long bones, typically, that produce movement. There are a couple of things that every synovial joint has in common. That they have not only the articular cartilage, which is highlighted here on the screen in the blue on the end of the bones, but there also is a fluid component to that joint that is contained within the membranes and the joint capsule that are around that. And what happens over time is that fluid will be reduced, or as we age, that fluid will become less viscous, and you will start to see a breakdown of that cartilage. And that's kind of the common thread, particularly when we talk about osteoarthritis, which occurs over time. Common locations: any joint is subject to arthritis. We see it most often in our weight bearing joints, particularly knees and hips. And other common sources of arthritic pain are things such as the base of the thumb, because it, particularly in today's day and age, when people are texting and kind of utilizing electronic devices a little bit more than they have in the past, we're starting to see more and more arthritic change around even some of the smaller joints. Common sources of pain. So you may hear a lot of, I call them the itises, in association with joint pain. So all itis, the last four letters of that word means is that it's inflammation. It has its etiology is kind of rooted in inflammation. So tendonitis is inflammation of the tendon. Tendinosis, which is kind of occurs when tendonitis goes on for a little bit longer period of time. You can actually start to see structural changes of the tendon. And we could see that on things like an MRI, such as with the rotator cuff or patella tendon or those kind of places. Bursitis is inflammation of the bursa. And a bursa is a sac of fluid. There are various bursas all over the body. The most common are the subacromial bursa, which is up in the shoulder area, the trochanteric bursa, which is on the side of the hip. And these are areas that are meant to allow passage of two hard structures over each other. For example, the trochanteric bursa has a tendon that glides over the edge of a bone, and there's a bursal sac that allows for that to kind of move freely across each other. And when that becomes inflamed, or that tendon gets a little tight and it starts to produce friction, that can be extremely painful. There, of course, is muscular pain as well, from muscular strains or calf strains and those kind of things. There could be ligamentous issues, and it could be a supporting tissue issue, such as meniscus tears and labral tissue, which are areas that kind of act as shock absorbers, particularly as it pertains to the meniscus for the knee. And of course, you get fractures, dislocations, but those are usually a different cause of a lot of joint pain. We're not going to spend much time on fracture treatment today, but the end result of a lot of these things over time is osteoarthritis. And the best way I know to explain this to people is I try to equate it to tread on your tire. That once you're 12 or 13 years old, you'll have all the cartilage that you're ever going to have for the remainder of your life. From that point on, it's a slow degradation process. So it's kind of like putting a tire on a car. The more you drive that car, the more the more you squill the wheels, or you're a little bit heavy-footed, the more that tire will wear down. And so that occurs with the joints as well, that over time, that cartilage will wear down depending on the amount of mileage you put on it, body alignment, injuries, all these other things. And of course, that also happens to correspond to age. The older you are, the more wear and more mileage you're going to put on each of your joints. So what is osteoarthritis? Again, we talked about that a little bit. It's degenerative joint disease is another name for that. And it affects well over 10%, well over 31 million people commonly, which is about 10% of the population, and that number is only going up with the baby boomers kind of reaching the typical arthritic age. Um, so as the joint gains life experience, again, this is what I was talking about. You accumulate injuries. If you are a paratrooper, compared to a cubicle worker, you're going to have more wear and tear. If you're a construction worker versus a cubicle worker, you're going to have more wear and tear. Again, if you're a football player for 30 years, you're going to accumulate more wear and tear. Again, the muscles around the joints also lose the strength. And one easy place to begin if you are having joint pain, a lot of times the excess weight is not helpful when it comes to our joints. Not only does it put more force upon those joints, so for example, the kneecap will see 7 times your body weight when you're going up and down stairs or squatting. So one of the places to kind of begin with people that have joint pain is maybe trying to lose a little bit of that weight. If you think about the kneecap example, if you lose 10 pounds, that's the equivalent of 70 pounds of force that is reduced coming across that kneecap. So that's an easy place to kind of begin, or at least an easy target to kind of begin with. What is osteoarthritis? How does it happen? Again, it's cartilage breakdown. Again, using that tire analogy, you're starting to kind of wear down the tread on the tire. It does produce some osteophytes a lot of times, and those are bone spurs that occur on the edge of those joints as that joint kind of begins to be worn down. And that actually, to some degree, helps to distribute the weight distribution across that joint, which is part of the reason why those bone spurs exist. How do we diagnose it? Well, first and foremost is x-ray, particularly weight-bearing x-rays. Oftentimes, if you come into our office, we will not only just get an x-ray of your knee, but we will also get a weight-bearing x-ray. And that's because on an x-ray, you're looking at the space in between the bones. And if you're just lying on a table, you may not see that. But if you're standing up on it, you will actually see the decreased joint space pretty remarkably. And sometimes that's the different. You will make the difference when we're trying to choose an operative intervention or non-operative intervention in some cases. As far as the severity of the osteoarthritis, people have heard of bone-on-bone arthritis. That's when all the cartilage is gone. There's minimal arthritis, which is very little of it's gone. You could just faintly start to see some decreased joint space that's there. And then we have moderate arthritis, which is kind of somewhere in between. So again, here's an example going back to that same picture we had earlier of the synovial fluid. Normal joint is on the left of the screen and an osteoarthritic joint is on the right. And you can see not only the decreased joint space, but the amount of fluid within that bubble is no longer there. And that actually is part of we'll talk about this in a little while. We talked about gel injections sometimes that we do for osteoarthritis. This is some of the concept behind that, is that if you can put more fluid into that joint, particularly if it's a highly dense fluid, that can produce a little bit more space in between the joint to kind of decrease the wear. And again, you can see the bone spur that's starting to form on that picture. So this is an example of knee arthritis. Here we're looking at essentially a normal knee. Okay, so you can see nice even joint spaces on the right side of the screen. And you can see kind of the schematic example of what that should look like. An osteoarthritic joint is quite a difference. So again, I'm going to go, so there's the normal knee, and then here's the osteoarthritic knee. So you can see the large amount of bone spurs that are there. Again, the schematic shows you how there are pockets of cartilage that are worn all over that knee joint. And you can clearly see the loss of joint space on the x-ray. And this is what we would term bone-on-bone arthritis. So in this example, that would be more of a severe case of that. Shoulder arthritis, here's a normal shoulder x-ray. Again, and a schematic of what that would look like. And then this is what an arthritic x-ray looks like. Again, we can see that loss of the joint space between the ball and the socket that is there. And this is one that probably will produce some creaking and cracking of the joint as those kind of bony surfaces are opposed to one another as the person is going through a range of motion. Hip arthritis, again, here is a relatively normal hip x-ray. I wouldn't say perfectly normal. There's a little bit of a bone bump on that right hip, but then we see here an example of obvious hip arthritis, and you can actually see flattening of the femoral head in this example on that right hip. Large bone spurs, and this is somebody that would probably do fairly well with, at least consideration of a hip replacement. So what are other injuries that can cause joint pain? So not all pain in the joint is arthritic. Once we get over probably about the age of 40, there's probably at least some arthritic component of almost all injuries to the joint. And sometimes that makes it very difficult to try to balance out where we believe that pain is coming from. If you have a severely arthritic joint, even if you have a meniscal tear, we're going to primarily probably treat that more as an arthritic joint than not. And I'll get into why we do that, because when we get to talk about some of the treatment options. Whereas the meniscal tear, if it's more, if you have a relatively normal looking joint, but a meniscus tear, that can cause extreme pain. And there are some fairly simple treatments for that. And again, a meniscus, for all those that don't know, I think I have a slide on it later, but it's a shock absorbing cartilage that sits in between the knee joint. And that will get torn up, in patients that have osteoarthritis, because as those bones get closer together, you can't really have them get to the bone-on-bone appearance without beating up the meniscus that's in between. But sometimes just a quick twist on the knee can cause a meniscus tear, and that can be treated easily. In the shoulder, we talk a lot about rotator cuff tears. Those are extremely common. There was actually a study that showed they took all people that came into the hospital and that did not have shoulder pain. So they screened out anybody that had shoulder pain, did an MRI, and out of those, 60% of those over the age of 60 had an identifiable rotator cuff tear on the MRI. Now, some of those were partial, some of those were full, but the point is, sometimes people are confused by the fact that they have a rotator cuff tear that by the time we see them has kind of been there for some time because they didn't have pain beforehand. For whatever reason, these do not always cause pain immediately. Sometimes it's something that there was a straw that broke the camel's back kind of a little bit later down the road. And then, of course, in hip and any of these joints, you can also have fractures, but typically there's going to be some sort of trauma that's involved with that. I'm not going to spend much time on the exercises for knee pain because the original presentation, I did this with a physical therapist, and he would actually get on a table and demonstrate this to everybody. I'm not going to do that for a variety of reasons. One of which is I don't have a table to do this, but you'll see these knee exercises. You want to do sit to stands, which are squats. You can do a lot of exercises as far as straight leg exercises to strengthen the hip flexors. And you may say, well, why do hip exercises for the knee? And that's because the two cannot be, they're not mutually exclusive. They have to be strengthened. The quad muscle and the hip flexors are vitally important to knee function as well. So these are things that therapists, again, can kind of run through with you if and when you go to physical therapy. Exercises for shoulder pain. Again, there's a variety of different exercises. As I tell my shoulder patients, whether they're rotator cuff patients that have had surgery or not, form is all important. If you're doing it with the incorrect form, then you're not going to get the ideal result from that exercise. And it's really hard. It's harder than you think, particularly for the shoulder, because it's a little harder to stabilize the shoulder. The knee joint is a straight hinge, joint for the most part. For the shoulder, it could go a lot of different directions, and it's your upper extremity, so you can turn your body if it gets a little painful. So you really have to kind of pay attention to the form with this. And they talk about really strengthening the scapular muscles. Why is that important? But you may say, scapula, does that really matter? It does, because it's one of the only bones in the body that is held to the skeleton primarily, almost exclusively, by muscles. So if that is not strengthened appropriately and that scapula is not positioned in space correctly, then that will lead to a lot of issues and, shoulder pain elsewhere, as the space just doesn't exist, for that rotator cuff to kind of move underneath that shoulder blade like it should. Here are some examples. Again, they're talking about the eyes, that you see up on the top, the T's that you kind of see in the middle, and the Y's. Again, this is something that a skilled therapist will kind of go through with you. But these are just some examples for not only strengthening the shoulder, but primarily the periscapular muscles. Now, hip pain, what are some exercises? Hopefully this slide looks familiar to most of you. And that's because I just showed it for the knee pain. It's the exact same exercises. So again, the hip is vitally important to the knee, and to strengthen the knee appropriately, the knee is vitally important to the hip. So joint pain, can it change over time? It can. And, really that degradation process, unfortunately, will continue despite our best efforts otherwise. We can do things to help eliminate or reduce these symptoms, but over time, that arthritic change will continue on, at least to the point where, a joint replacement does put a stop to that. But up to that point, that there's really no way to kind of pause that entirely. Again, with osteoarthritic or joint pain, we tend to see a decreased range of motion. So when to see your doctor? When the easy things that you could do aren't making the appropriate improvements. And what I mean by that is, if it only hurts when you run and you're not much of a runner, then stop running. Do something else. If that changes the pain that you're having, then you don't necessarily need to come in to see somebody. If you're having persistent swelling despite taking anti-inflammatories, despite doing those activity modifications, then that's the time to kind of come in and see what we think may be causing it. We have a multidisciplinary team here at Premier Health, and they're quite skilled, and we're pleased to be associated with everybody from our physical therapists, who are awesome, to our primary care physicians, who are phenomenal in getting people kind of ready to go and treated appropriately from that point of care. What does your doctor want to know? We want to know the location, the duration of the symptoms, how long they've been there, whether it's a burning pain, whether it's a sharp pain, whether it's an achy pain. And ultimately, it is also important what your goals are. If your goal is to get back to regular activities of daily living without pain, then that's different from the person that wants to get back to playing professional baseball. So it's important to kind of know what those goals are. That way we can hope to achieve them together. Other treatment options, here's a long list of other things, and there may be some questions typically on some of these. There's a variety of vitamins and herbs and nutritional supplements that are out there. A lot of them, there's limited, blinded, peer review data to, kind of give us a sense that they are highly successful or not. But most are safe. A glucosamine and chondroitin is relatively safe. But again, does it really make a difference? I could show you 10 studies that show it does, that it does, and 10 studies that shows that it does not. Again, lifestyle modifications, weight loss is a big one. Again, every pound of body weight is 4 extra pounds of pressure on the joint in general. And there are some joints like the kneecap that it's even further increased than that. Easy, or maybe not an easy one to kind of cure, but one thing that leads to poor outcomes across the board is smoking as well. So those are important to kind of hit. Lifestyle modifications, certain anti-inflammatory type foods, flaxseed, omega-3s, olive oil, all those kind of things are good, but mainly having kind of a nice balanced diet is key. Exercise and activity. Again, that's very healthy for people. I personally am a fan for anybody over the age of 30 or 40 for primarily sticking to joint friendly exercises. What are joint friendly exercises? Well, it's mainly avoiding running and jumping. So elliptical, biking, swimming, those are great exercises that produce very low impact on the joints. Again, it's about minimizing the amount of wear and tear to those joints over time. And unfortunately, by the time the arthritis is set in, we don't have the ability to kind of, put the car into reverse and back that up. So we need to, try to kind of make those activity modifications early on. Um, Again, guidelines, light to moderate, intensity, particularly with walking, cycling, and aquatic therapy are great. And try to be consistent at that. Trying to keep good muscular tone and those kind of things are very important. The goals of physical therapy are to try to get you back to normal. And with that, there are a lot of things that they can work with you, including activity modifications. They have a lot of modalities that help to reduce the pain and improve that range of motion. And primarily, where they really help is kind of building the strength of a lot of these joints that help to stabilize. Again, we talked about osteoarthritis. This is just kind of thrown back in there for review. Osteoarthritis typically results in decreased mobility or range of motion, decreased strength, and increased pain. What is one way when people come to see me that we tend to treat these? Well, we a lot of times will offer injections, to patients, and there's a variety of types of injections. I'll kind of hit on two specifically here. One is the cortisone injections, and these are not completely innocuous. So we do try to be good stewards of how often we utilize these steroid injections. But the important thing, these are very successful, very quickly successful in eliminating the patient's inflammation in that joint, and as a result of that, their pain. So oftentimes when people have tried everything, they're kind of at their wits' ends and they're having life-altering pain. This is a quick treatment that could kind of produce good results. They typically last 3 to 6 months on average, but again, the worse the severity of the arthritis, the less length of time that would occur. We do have to be very careful about how often we use these. So I try not to use these any more than every 4 months, so no more than 3 a year. And even then, there is a certain number, whether it's 5 or 6 or 7 injections, that by the time you kind of get to that many, we probably need to kind of explore other options. And the reason is that steroid can actually soften the cartilage, which I tell people is kind of robbing Peter to pay Paul. So you're softening the cartilage in a joint that was already seeing increased wear, and that can over time accelerate that wear. And so it does great with these symptoms, but we don't want to kind of cause worsening of the progression of that. So we try to be judicious in the use of that. Gel shots, we talked about that a little bit earlier. So that's the other type of injection that insurance companies pay for and we commonly utilize. The nice thing is this does not use a steroid, so we do not have to, I say, be as cautious, with this. The downside is the insurance companies don't pay for it, but every 6 months. So it tends to be an every 6 month kind of event for most of the insurance companies. And it is a highly concentrated concoction of the hyaluronic acid that is normally in a knee. They're often synthesized in rooster combs. So some people call them rooster comb injections, but it is basically a lubricant for the knee. And it helps to produce more fluid within that joint to kind of get those bones that are rubbing against each other a few micrometers of additional room so that those surfaces can rub across each other with less friction. And it does work pretty well. Unfortunately, it doesn't work quite as quickly as the steroid injection. So oftentimes it'll take 3 or 4 days or maybe even a week to kind of really see the relief after that. So what about surgery? Well, again, we're kind of, primarily talking about osteoarthritis, which is one of the common causes of joint pain. And how do you know when surgery is right for you? Well, from an arthritic standpoint, if you have severe arthritis, I tell people, you know it's right when you, not when you come in and say, hey doc, when is it right for me to have surgery? You know it's right when you come in and say, I am done. I'm finished with this. I'm ready to move on to the next step. Now that's for something like a joint replacement, but there are some situations, particularly for a simple meniscus tear, those kind of things where a knee scope or shoulder scope or a hip scope offer a perfectly reasonable solution that will, by hopefully an extended period of time, of relief from whatever is bothering you. And those are typically minimally invasive surgeries. So some of the questions you'll need to ask, things such as, well, I need physical therapy. What is the recovery? And will you need assistance at home? Those are all important questions to kind of have that conversation with your physician once you feel like you've exhausted the non-operative measures. So what are our options? Again, scopes. In general, for most joints, we're talking about scopes or joint replacements. If the arthritic change is down to that severe category, scopes do not treat arthritis. And so I just want to make that clear. A lot of people will say, well, I had my joint cleaned up. We're not really cleaning up the arthritis that's there. We may be kind of smoothing it out a little bit so that it catches a little less often. But there's no way with a scope to really get rid of the arthritis. The one thing you can do with the scope is you could treat the other things that are causing pain. So the meniscus tears, the labral tears in the hips or the shoulders, the rotator cuff tears. And if the pain seems to be coming more from those things than from the arthritis, then that balancing act would indicate that a scope is a very reasonable option for them. If we think that the patient has bone-on-bone arthritis and 80% of that pain is coming from the arthritic standpoint, then a scope really does not typically provide much relief. Within the world of joint replacements, we do have partials and totals for, particularly for the knee joints. So what is arthroscopy? Well, it's looking into the knee with a camera. You generally will have 2 or 3 poke hole incisions. We'll look in one with the camera and kind of use some instruments in the other. Again, it does not really treat arthritis, but it is a wonderful treatment for meniscal tears, labral tears, rotator cuff tears, and it provides a nice minimally invasive way to do that. The recovery is generally a lot quicker than that of a total joint. And therefore, in the right situation, I think it's a wonderful asset. And if somebody just twisted on their knee, they have minimal arthritis and a big meniscus tear, then I think it's a wonderful treatment if they have failed the other non-operative measures. What's the good of it? Well, it's minimally invasive. It's outpatient, generally speaking. And it has a very low risk. The bad is there really are limited indications if one of the main reasons you're doing it is for arthritis. But it is, a good treatment for things like meniscus. It's best when the pain is kind of acute or when there's mechanical symptoms such as, say, a meniscal tear that is getting caught in the knee where it's causing popping and locking of that joint. When should you consider a joint replacement? Well, as I told you earlier, I tell people when you come in and say, I can't take it anymore, I'm ready to move on. I'm tired of these injections. I'm tired of chasing my tail and just having this pain come back every 3 or 4 months. When it's affecting your quality of life and everything that we can provide is not giving you the ability to, live life like you want to live it, then that is the time to consider a joint replacement. Knee replacement is shown here. It's done extremely commonly, and probably this number is a few years outdated since I did these slides previously. Again, we could do total joints, which mean that we're replacing all the surfaces within the joint, or we can do unicompartmental joints or partial joints, which are replacing only one part. So we could do kneecaps, we could do the inside of the knee or the outside of the knee. Here's an example of a unicompartmental knee replacement. Again, these are the before x-rays. You can see on the left that there's narrowing just on the one side of the joint. The other side of the joint actually looks okay. So what do? Well, we come in and we will replace that, and you can see that we kind of cut away that area. What you don't see in between the 2 pieces of metal, and there's a marker there, is the piece of plastic that sits in between. So there's a piece of plastic sits directly in between that. And this works wonderfully well for, particularly for younger patients with arthritis. in my practice, this is primarily for that 40 to 65-year-old patient that has primarily one-sided arthritic change. Because really what happens is these over 10 or 15 years, the other parts of the knee start to wear out just because they're still accumulating that mileage that we talked about. And if you're young, that helps to kind of get you to a point where you can get to a full knee replacement later with no issues. But if you're 65 and older, oftentimes, we could talk about that, but the total joint replacement may be the better one-time surgery because you probably won't need anything for the rest of your rest of your time. So total knee replacement, this is an example of that. Again, you can see pretty arthritic knee before the surgery, and this is what it looks like after the surgery. So I also do a lot of hip scopes. I just want to explain this. This is something that we think causes a lot of hip arthritis. You can see, a normal hip joint should be a ball and a socket that works perfectly together. Unfortunately, not everybody's made that way, and we have some people have bone bumps on the femoral or on the ball, which we call a cam lesion, and some people have an extension of the socket that causes pinching of the ball and socket joint, and we call that femoral acetabular impingement. A hip scope is a very good treatment for that if we identify that before there's too much arthritis. So again, we could treat labral tears, some cartilage damage, but eventually that does become osteoarthritis if left untreated. So we do a workup, including injections, MRIs. Usually we'll try a non-operative treatment. And sometimes that results in us needing to come to do surgery. And this is a picture of a intraoperative photograph of a labral repair that we did for a patient, a younger patient. So just understand that for hip pathology, total joint is not the only game in town. It is if you have severe arthritis, but for a more mild arthritic change, sometimes hip arthroscopy is a reasonable option. So seeking somebody that does this may be reasonable. Hip replacement is about half as common as a knee replacement. Here you can see an X-ray of a horribly arthritic right hip. Here we show resurfacing. This really isn't done that much anymore, and the primary reason behind that is there's been a lot of concern about metal on metal wear. This used to be what we did for young patients that had hip arthritis, but that has kind of been supplanted by hip arthroscopy for the most part. There are still a few people that are out there that do this, and it does very well. I mean, if you look at the data, it actually does pretty well, if done right, but there's so much concern about metal on metal issues with this that the vast majority of people don't do that anymore. Total hip replacement is sticking a stem and into the inside of that bone, cutting off the current ball and replacing that ball and socket. And you can see an example of that here. And here's what that looks like on X-ray. Real quick, and I only have a few more slides and then we could kind of wrap up for questions. Some recent advances in hip and knee arthritis treatment, I think, has been the robotic platform. And the one I'm more familiar with is listed here on the screen, but Premier Health actually does have two different options with regards to robotics. They have the Mako, which is a Stryker product, and then they have the Rosa, which is a Zimmer product. And there are at least 3 hospitals that are utilizing that, along with probably 8 surgeons that are skilled in performing these robotic joint replacements. I do want to dispel a myth. Robotic joint replacement is not like AI. I'm not Will Smith. This is not AI. We don't have robots standing over the top of you doing surgery, with us standing in the corner, kind of playing video games. That is not what this is. This is a tool to allow us to really kind of direct the precise cut. And to me, the really cool part of this is the brains behind it, the computer behind it that allows us to take a CT scan of your knee or your hip, put that into the computer, and we can see real time how lax your knee is, because everybody's knee is a little different. So sometimes they're a little tight on one side, a little loose on the other. And it allows us to adjust the cuts of the bone such that we get a perfectly balanced knee every time. Why is balance important? Well, that's how the implants are designed. So what we've done in the past conventionally is we'll make the cuts wherever we think they need to be made. And then we get in there and realize they're not balanced well. And then we'd have to do soft tissue procedures to kind of basically cut some of the things to kind of make it balance out. Well, as you can imagine, soft tissues are not necessarily made to be cut. And I think that presented a lot of issues. And that's the reason why I think knee replacements have always had this 20% of people that just didn't do as well as we felt like they should do. Their x-rays look good, and, but there are 20% of people that just did not do as well as you'd hoped. And I think robotics has really revolutionized this completely, that it allows us real time before we ever make a cut to get that implant perfectly positioned so that we never have to do I've yet to have to do one, knock on wood, a soft tissue balancing procedure to get that right after the robot is done. So we could change that, the placement of that implant just by a millimeter or a degree here or there, and it can perfectly balance the knee and the hip to allow for that precise cut. And then all the robot does is, you can kind of see on screen here, I'm still pushing the go button, and I'm still utilizing this, but it allows me to put that cut exactly where we want it every time. And the ROSA is very similar to that as well. So what are some of the advantages? Well, there's less pain. We think that people recover easier. I will tell you my own practice. I thought I was doing it pretty well beforehand, but I'll be honest that people were coming back with 15, 20 degrees more range of motion at that very first post-operative visit. And it's pretty remarkable. There are some very difficult cases that are made very easy when you can see all that bone in real time, and you can make those slight adjustments just to get that perfectly placed. So, I don't think there's ever been an industry where robotics was introduced where it was removed, because it almost always, as much as we hate to admit it, it almost always makes that a more efficient process. And, in this case, I think that it's no different. Again, with Mako in particular, they have over 14 plus years of experience. This number has only gone up over the last year. We're one of the systems that has kind of added that over this time. So how does it work? Well, you can see the picture of the Mako there. We personalize the plan. That we do that before we ever step into the operating room. When we step into the operating room, we make some adjustments, to that, just depending on soft tissue laxity. And then what we really do there and too is that we then use that robot to kind of take away the bone only where we want to take it away. And there's also an added protection to this, that it doesn't allow the saw to go anywhere where it shouldn't. So you can only cut the bone. If I try to cut anything other than the bone, it will shut down the saw. So not to say that I would ever do that, but the point is, it does add an element of safety into this as well. So again, review: joints give us freedom to move and perform daily activities. They also can cause a lot of pain. And I think that's why everybody's online. I'm sure there are tons of questions, so I'll be happy to take any of those questions. Again, there's some individualization of treatment plans that really should be kind of discussed, in person, with looking at your x-rays and those kind of things, but I can answer kind of general questions, for that.
So our first question is, should you have both knees replaced at the same time?
That is a wonderful question, and actually was brought back to light a little bit more recently. I'm not one that does a lot of bilateral knee replacements, because I've always kind of worried about the increasing of risk at the time of surgery. That a single knee replacement, I tell people, is kind of like doing a half marathon. But if anybody's a runner, there's a big difference in doing a half marathon and training for that and doing a marathon. And so doing both knees is kind of the marathon equivalent. There was also a recent study that did show that there really are increased complications with bilateral knee replacements. that can be avoided by just doing it on one side first. So I won't say I've never done it. I have. I think it takes a special person and a special situation, particularly if they don't have enough time to kind of recover from both individually. But it hurts twice as much, and it you know in some cases can kind of set back the recovery on on an individual side. I mean, you can kind of get a little bit better result if you can kind of zone in on one side versus the other. But there are definitely ways to do that successfully. In general, I find it hard to kind of find the right person to kind of do that on, and I usually kind of talk people out of that a little bit. Um, but that's just a personal preference. I know plenty of really good surgeons that do bilaterals, and they do them very successfully. And the papers are out there to show that you can, but I do think it's a little bit more risky. So it depends on the person and the situation, I think, a little bit. I would tend to say, unless you have a strong reason to do it bilaterally, I would do one individually. And usually the way I do it is 6 weeks apart. So I would do the right knee, and then 6 weeks later do the left knee.
Okay. Our next question is, how do you determine if a patient is a good candidate for robotic joint replacement versus non-robotic?
I honestly, right now, I'm doing everybody just about robotically because I see no reason not to unless the patient has a strong preference one way or the other. Again, from what we do during the surgery, the process is still the same. I mean, we're putting the implants in very similarly where, we want the joint to be balanced. Um, all the things that we try to achieve when we're in surgery are really improved by robotics. So I think it's just a tool that allows for better placement. And I see really, I mean, if I were to have my knee done, honestly, I would have it done robotically. It's so it's not so much picking individuals to do that. That's just kind of what my standard offer is. Again, if somebody does not want it done robotically, we do have the ability to, I say, do it conventionally. But a lot of times when you kind of talk through what it is, again, it's not a robot doing the surgery. It's just an aid. It's a tool, to allow you to be better. And I equate it to, not that I'm Jack Nicklaus, okay, but I equate it to giving Jack Nicklaus, GPS in today's, irons and woods. You're giving him tools to be better at what he does. It's, and it's not a knock on, the old way of doing things. It's just, it improves things. It does. It takes away the outliers. It takes away, those people that have more laxity than you expected. And again, soft tissue balancing procedures really don't work very well. And so you're much better balancing before you ever have to get to that point.
Our next question is, do joint replacements last forever?
No. Good question. The honest answer is we don't know how long they last. How do you like that for a hedge answer? The reason why I say that is the old things that have been in for 15 to 20 years used to last for at least that long. Our new data, we think most knee replacements will probably last for 20 plus or minus 5 years, and most hip replacements will probably last for about 5 years longer than that. So 25 plus or minus 5 years. But that really is based on laboratory data and wear tests that are done in a lab, because these new stuff we're putting in over the last 5 years haven't been in for 25 years. So we really don't know when that is going to fail. We've solved some significant issues when it comes to the wear of the pieces of plastic that wears at 1/1000th of the rate. Also, one thing that I try to do with not only hip replacements, but also almost all my knee replacements is a different way of getting that implant to kind of seat to the bone. And so the old way of doing that was to kind of use cement. And I would still say that that's probably still the gold standard, but you just kind of basically glue that that implant in there. The problem is after about 15 years, that metal may rock free from the cement behind it. And I tell people it's kind of like a brick and mortar. then once it rocks free, it never rebinds. You can't just go in and tuck point it and kind of get that to work again. So what a press fit design is intended to do is it has it has little porous holes in the back of the metal that allow your bone to grow into that. And it produces a biologic fixation as opposed to using cement. And so we think that in 25 years, or now probably 10 or 15 years since that has been introduced, that we're going to really see a dramatic shift in how many of those are loosening at that 15 to 20-year mark. And we're just now getting to the point where those have been around for that long. So I think over the next 10 years, we're going to really start to see whether or not that theory was correct. That they at least do as well as the cemented. But I think that we're going to see those last longer and longer. And I mean, I wouldn't be surprised to see the stuff we're putting in now last 30 years, but forever, no. I mean, 60 and over, you're probably safe to get a total joint or a total hip or knee at least, and that will last, the rest of the time. If you're 60 and under, that's where sometimes we have a conversation about should we do a partial if it's really bad just in one area to kind of buy 10 or 15 years to kind of get to that point. But yeah, not forever, but 30 years isn't bad. It's getting there, and we'll only get better over time.
We have one final question, so I'll make this last call for any additional questions. What if you have minimal arthritic pain, but your gait is off, and it makes it difficult to walk without creating stress on the leg, foot, and hip? Is that a possible reason to consider joint replacement?
It is, depending on how much it is affecting those other areas. Like I said, I tell people that if the x-rays show moderate to severe arthritis, but you're actually having minimal pain there, but it is throwing everything else off, that may affect your quality of life just as much as having horrible pain to that knee. The thing you have to be very careful with in that scenario is making sure that the pain in the hip and the ankle and the back or wherever that is not attributed by something else as well. Because you don't want to, I say, put all your eggs in the basket of this is my knee that is causing, this issue. And that's what the therapist told me. And therefore, and in reality, you may have a little bit of hip arthritis or a little bit of back arthritis that is kind of pinching a nerve, that's there, because clearly knee surgery is not going to affect those issues. So it's important for us to be thorough in the workup to eliminate that. But there's no doubt that if you're unable to have the full range of motion to your knee and it is affecting that gait, the spine is a big Jenga column that sits on top of our lower extremities. Any effect in our gait is going to affect that. It's also going to affect the adjacent joints, the ankle and the hip. And it would be reasonable to consider that if you can really kind of nail it down that is where it's coming from. There also may be other options involved, as far as whether or not they've done therapy and whether or not that would be helpful as well.
Okay, well, thank you, Dr. Powell, for your informative presentation this evening. We appreciate your time and your expertise. And I want to thank you all so much for being with us this evening. I hope that you found the information that we shared useful. We feel very privileged to be with you tonight, and I hope that you consider us for any healthcare needs you may have. If you'd like to learn more about Dr. Powell or his practice, Premier Orthopedics, you can visit premierorthooh.com. And more information about Dr. Powell can also be found on his bio that was sent, along with the information to access tonight's event. Should you have additional questions or would like to make an appointment with him, his office phone number is on both the practice website and on his bio. And last but not least, as a reminder, this seminar was recorded, so we will email you a link to the recording should you want to go back and listen to some or all of this great content again. And as soon as it is available, we will share this URL to access the recording. So with that, we wish you all a very good evening. Thank you again for joining us, and stay safe.
Absolutely. Thank you, guys.